Hello, everyone, and good afternoon, good morning, good evening, depending on where you are. And welcome to a very special ERS ATS Journal Club. Today, we'll be talking about the manuscript Adherence to CPAP Treatment and the Risk of Recurrent Cardiovascular Events, meta-analysis that was recently published in JAMA. We're grateful that everyone is able to join us today, and we're pleased to be joined by several of the authors as well as panelists. And I do want to thank everyone for their patience with rescheduling this event. Just to introduce the format for today, we're going to start with brief introductions of our guests, and then we'll discuss the learning objectives and move into a brief PowerPoint presentation that Dr. Kunisaki will present describing the paper, and then move quickly into what we hope is a pretty lively and spirited discussion around the paper. As we do so, we have some prepared questions that us as moderators will present to the panel, but we also welcome questions from the audience. We can't guarantee that we'll be able to answer all the questions, just because there's going to be a large number of you in the audience, but we will do our best to ask what we can. Without further ado, first want to allow our moderators to introduce themselves. I'll start. My name is Luke Donovan. I'm an associate professor from the University of Washington, and I'll allow Dr. Kunisaki and Dr. Schwartz to introduce themselves.
Hello, everyone. I'm Ken Kunisaki. I'm a pulmonologist at the Minneapolis VA and University of Minnesota here in Minneapolis.
Welcome also to everybody from my side, and thank you to the ATS and to the ERS for making this great collaboration possible. My name is Esther Schwartz. I'm based in Zurich, Switzerland, and I'm the secretary of the Sleep Disorder Briefing Assembly of the ERS. And I like to share with you the learning objectives of today. So the aim is to gain knowledge that allows to critically evaluate the role of CPAP adherence in cardiovascular prevention in OSA, and to understand the determinants of the CPAP adherence. And we should also gain knowledge that helps to be aware of biases and different confounding factors in different study models. And now it's my great pleasure to introduce the authors of the individual patient data meta-analysis. So as Luke has mentioned, we have several of them here. And let me start with Manuel Sanchez de la Torre. He's the professor of faculty of the medicine at the University of Lleida in Catalonia, Spain, and the deputy director of the Biomedical Research Institute in Lleida. He's the first author of one of the RCTs of the ISAC trial. And we are also very pleased, Manu, that you are an ERS officer and you serve as a group chair of basic and translational science in our assembly at the ERS. So welcome, Manu. Thank you for bringing us all together. Then we have Kelly Loeffler. So she's a senior researcher with a biomedical science and biostatistician background from Flinders University, and one of the steering board members of the SAFE trial with a lot of experience in clinical trial design and analysis. Also, particularly in the field of cardiovascular effects of OSA. And then it's a great pleasure that we have Doug McAvoy here. He's Professor Emeritus from the Flinders University and the former director of the famous Adelaide Institute of Sleep and Health at Flinders University. And of course, the well-known principal investigator of the SAFE trial. Then it's also a pleasure to have Yüksel Peker here. He's professor of the Department of Pulmonology at the Medicine School of Koç University, sorry if I pronounce it wrong, in Turkey, Istanbul, and the principal investigator of the Recurrent trial. So thank you all for being here, and now I hand over to Luke again.
It's my pleasure to introduce our panelists. So first we have Dr. Silke Ryan, who's professor of medicine at University College Dublin in Dublin, Ireland. And she has a wealth of expertise as a physician scientist and clinical researcher, leading trials and research around cardiovascular disease and sleep medicine. We're also joined by Dr. Daniel Gottlieb, who's associate professor at the VA Boston Healthcare System. as well as Brigham and Women's Hospital in Boston, Massachusetts, and Harvard Medical School. He has a wealth of experience around the cardiovascular effects of obstructive sleep apnea, as well as relevant experience in observational studies, as well as clinical trials. And finally, Dr. Amy Sawyer, who's Associate Professor at the University of Pennsylvania School of Nursing and the Perelman School of Medicine and Chronobiology and Sleep Institute at the University of Pennsylvania in Philadelphia, Pennsylvania. Her expertise centers around the determinants of adherence and ways to improve adherence, particularly to positive airway pressure therapy. And without further ado, hand things over to Dr. Kunisaki.
Great. Thanks, Luke. All right. And so Miriam, okay, great. Thank you. We got some slides here. Share. Okay. Great. Well, thank you very much. And again, many thanks to our global panel of authors and speakers, especially with all the around the world. It's nearly midnight for Drs. McAvoy and Loeffler, and it's 5 a.m. for Dr. Donovan. So always ironic when it's a paper about sleep. So, all right, so by way of background, we know that the risk of cardiovascular disease is high among persons with sleep apnea. CPAP is first-line treatment, improves symptoms and blood pressure. But the question about prevention of cardiovascular events has been addressed by 3 large randomized trials listed here and referenced below that tested the impact of CPAP on secondary prevention of cardiovascular events, each of which failed to demonstrate an effect. However, there was a key concern about inadequate CPAP adherence in these trials, which is what this paper today addresses. So that brings us to this Journal Club paper. Published in October in JAMA, which addressed the primary question, is CPAP treatment for OSA associated with decreased risk of cardiovascular adverse events in participants with both sleep apnea and established cardiovascular disease? The established CVD here meaning secondary prevention of future recurrent events. So this is the approach of this paper. It was an individual patient data and IPD meta-analysis. Initial data search found over 1,800 references, of which 340 were unique articles, which were included 24 randomized controlled trials. Of those 24 RCTs, 3 of them met the criteria for this meta-analysis, as previously referenced. Here's the flow, so about just over 4,100 participants included in this meta-analysis, about evenly split into those that were assigned to CPAP versus no CPAP, and you can see by the numbers here the relative distribution of the sample size between the 3 randomized trials. And the primary outcome here was looking at MACE, major adverse cardiac or cerebrovascular events, or MACE-related death. And the IPD here is really the unique part. Required the authors to obtain pretty complex data sets from each trial, detailed to the level of each participant in each study. So this was undoubtedly a major effort, but allowed the sophisticated analyses that follow. So the primary analysis here was intention to treat, exposure being the randomization to CPAP. That was the primary meta-analysis. But then, I think what we'll discuss a little bit more is this on-treatment analysis. So this was looking to not only randomization to CPAP, but also CPAP adherence, dichotomized at a cut point of 4 hours a day at each time point along the trial. Additional methods include MSM, marginal structural models, with inverse probability of treatment weighting, adjusting for both the baseline and time-varying confounders. The term time-varying here, meaning that the authors were able to adjust not only for factors at baseline, but also, that's the usual approach, but also repeated measures of the confounders during follow-up, at which point those confounders were updated and measured again. So for those who do a little less epidemiology work, this is a directed acyclic graph, or a DAG, to assist in thinking about confounding, which is always one of the major issues in causal inference in observational studies. So here we have baseline confounders here. in red, outlined at the bottom here. So recall that confounders are defined as factors that directly affect the exposure variable. In this instance, it's an adherence and the outcome of a cardiovascular event or MACE here. And then we also have time-varying confounders. So in this case, body mass index and Epworth Sleepiness Scale, confounders that can change during the course of follow-up and were considered not only at baseline, but also during follow-up. And then lastly, as in all observational studies, there are also always possible unmeasured confounders. So for purposes of this journal club focused on the adherence work, we're just showing you a subset of participant characteristics from the online supplement, just so you can understand who's in these studies. So the two columns here are only those assigned to CPAP in the trial, split into those with on the left poor versus on the right good adherence, dichotomized at that 4-hour mark. You'll note that the average age is around 61 years, mostly men with a BMI around 28 and an expectedly high prevalence of hypertension. Those with poor adherence were more commonly current smokers, slightly less hypertension, and slightly less severe OSA metrics. Importantly, Epworth sleepiness scores there at the bottom were 66 to 7 on average. So we should note that these persons had generally minimally symptomatic OSA. So again, in terms of the techniques for the analysis, the survival analysis for MACE analysis, two approaches was a one-stage individual patient data meta-analysis with methods listed here, and then a two-stage one where a Cox regression was fit separately for each trial, and then combined using a random effects meta-analysis approach. And so for the primary analysis here, we see no overall effect of CPAP on MACE, and maybe not really surprising knowing that each trial itself showed a null effect. And then here we focus again a bit more on the adherence analysis, where median adherence was only about 3 hours a night. Again, raising concerns that the dose, and again, that's my words, not the author's word, but the dose of CPAP may have been inadequate. So when considering adherence, the authors find that those that had more than 4 hours a night of CPAP use had significantly less MACE events than non-adherent trial participants. So this was true in analysis on the left, considering baseline and those time-varying covariates I showed you earlier, and also in a sensitivity analysis on the right that censored at the first switch in adherence. So if someone went from good to poor or vice versa, they were then censored at that time. So these are the adjusted hazard ratios along with the 95% confidence intervals here. Again, showing that adherence was related to this outcome. So the key strengths, again, this IPD approach is geographically diverse participants with really good capture of both exposure, CPAP adherence, the outcome of MACE, and the covariates, including, importantly, I think, the time-varying covariates. And again, the team science, I'm sure this was countless hours of work from the study team. So they're really congratulated on their spirit of collaboration here. A few limitations, like in all studies. In this study, there were a few women, about 18% of trial participants. CPAP was the only OSA treatment assessed, so nothing like positional therapy, oral appliances. And there were relatively few patients with significant OSA symptoms by way of Epworth scores. And then the one thing I think we'll talk a little bit more about is this healthy adherer effect. So, this term in epidemiology, the healthy adherer effect or healthy adherer bias. This is one example here on the right from the Women's Health Initiative, where persons with high adherence also had lower mortality than those with poor adherence. But interestingly, the intervention adhered to here was placebo. Just to show this another way graphically, this is another example from a heart failure trial where the y-axis is the proportion alive over the x-axis of time. And those who adhered to an angiotensin receptor blocker, candesartan here, those who adhered in orange, were more likely to remain alive than those who did not adhere well there in red. Interestingly, this also conducted the same analysis in those who were randomized in this trial to blinded placebo. And when they looked at that group, They also found that poor adherence to placebo in the dark blue was associated with worse outcomes than good adherence to placebo in light blue. So other papers have demonstrated this healthy adherer effect, but often have used pooled overall measures of adherence rather than the more sophisticated approaches used in the current paper. So things like the time varying analysis, marginal structural model, and individual patient data. So although we're going to focus today on a sleep intervention, we hope this journal club will also provide helpful insights into analyses of adherence data more broadly for ATS and ERS members who might be considering analysis of adherence to other things in our field, like oral medications, oxygen, or inhalers. So with that brief summary of the paper that I hope I've done justice to, I think now we're going to move on to the panel discussion. So, great.
Thank you very much, Ken, for this excellent summary and also the background information on the healthy adherer effect and the potential confounders. And now we can start the discussion. We have a first question that goes to the authors. So from your point of view, which are the most important strengths and what are the most important limitations of your analysis?
Okay, I will start to thanks about this wonderful journal club. I want to thank also to Ken Gunasaki for this wonderful summarizing of the work, and also to highlight the importance of the team science. I also agree with this kind of approach. So, okay, I think that it will be very, very interesting and inspiring the discussion that we can have here today. And I have some points to share with you about the strength and the limitation. And I want to highlight, at least in my point of view, about the three strengths. The first is the multi-century, multinational, individual patient data meta-analysis that have allowed to perform this kind of sophisticated statistical analysis, as mentioned again before. The second strength is the CPAP compliance. When we try to summarize the mean compliance in a trial, that we have a follow-up of several years, I think it's inadequate to divide this entire time in one or two groups, because we need to evaluate the CPAP compliance longitudinally, looking for period time of use and not an aggregated mean value. Okay, so I think this is the second strength. And finally, the third strength is that the causal inference in individual patient data meta-analysis allow us to consider CPAP compliance more representative of real use and real effect, because we can compare with this kind of analysis full users versus not full users.
So I guess I could follow up. First, I want to congratulate Manu and Doug, Yüksel, and all their teams for conducting these randomized clinical trials, which are very difficult to do, but they're critically important to our field. And I think that these trials are hopefully a down payment on future randomized trials in our field. They're important because they give us information about who benefits from what treatments and in what way they benefit. They're also important because sometimes they show us things that we're not expecting. And I think that most of us were not expecting to see a null result from these secondary prevention trials. And I think that these studies taken together provide strong evidence that CPAP therapy, at least as conventionally administered, is not effective for secondary prevention of cardiovascular disease in patients with asymptomatic or minimally symptomatic obstructive sleep apnea. And that's, and I think that was the primary analysis here showed, an hazard ratio of 1.01, no effect. Now, confronted with those findings, it's important to think about why it is that the findings differed from our expectations, and the potential reason that was focused on in this paper was that low adherence may have been the reason that we didn't see an effect, and they showed roughly a 31% reduction in risk with in patients who are adherent compared to patients who are not adherent. But unfortunately, I think that the comparison of adherent to non-adherent patients is almost always going to be a flawed analysis, and can show that patients who are adherent compared to patients who are not adherent, even when it's to placebo, something we know is not effective, the effects are very strong for being adherent. And this healthy adherer effect has been demonstrated repeatedly over at least 4 decades in cardiovascular clinical trials, also in trials in other fields, such as the TORCH study, which found that inhalational therapy for COPD, that placebo was associated with roughly a 50% reduction in both hospitalization and mortality, and on with the prostate cancer prevention trial, with the Women's Health Initiative that Ken mentioned. So this effect is very large. It's been seen in multiple studies across diverse conditions, and we don't know what the mechanisms are. But the typical things that are easy to measure, and even some things that aren't so easy to measure, such as exercise and socioeconomic status, explain only a very small proportion of the healthy adherer effect in previous trials. And while the adjustment for confounding in this study was fairly sophisticated, it can adjust for things that aren't included in the model, or at least are not strongly correlated with things that are in the model. And I don't think we have any reason to expect that the factors underlying the healthy user effect are accounted for by those things. So my concern is that what the adherence analysis here did was really to recapitulate what we've known for decades, that being adherent to therapy, regardless of whether it's an effective therapy, is associated with better health outcomes. And I think that we probably ought to be looking for other potential explanations for why these trials had null findings. And I think that some that have been suggested include that these were non-sleepy patients, and there's a number of studies, not all studies, suggesting that it is the sleepy patients with sleep apnea who are at greatest risk of cardiovascular disease. Another is that these secondary prevention trials, patients are on multiple cardiovascular protective therapies, antihypertensives and so forth, and they may be treating the downstream effects of sleep apnea. It may be that we can't see additional benefits from CPAP. But I'm concerned that the conclusion that what we need to do is to get our patients to use CPAP more may have some real world negative consequences, because I think that without good evidence that we're actually reducing risk by increasing their CPAP adherence, we're causing them we're counseling them to increase their use of a therapy that is costly, that they don't like, and that may in fact worsen their sleep quality in the expectation of seeing cardiovascular benefits that I don't think we've demonstrated exist.
Mhm.
Any other comments from the authors around the strengths and limitations?
Yeah, I agree with this observation from Daniel about, of course, one of the most important limitation of any post hoc analysis is that you are not protected against potential bias. Some of them are unknown, or the healthy user effect. When we apply this kind of marginal structural models, we generated comparable representativeness of confounding variables between groups. And when we plan to explore this individual patient data meta-analysis, we design a causal association hypothesis that was represented with this direct acyclic graph that Ken have shown before, and consider well-documented potential confounding variables that could affect CPAP compliance and the risk of cardiovascular recurrence, some of them at baseline, some related with the antihypertensive drugs, and some of them related with the adherence of the treatment by the patient that could be affected by the change in body mass index, by the change in the symptoms, thinking also that we have asymptomatic patient, but we have some effect in the Epworth scale score, and we have this result in the SAFE study. but also we take into account this time variant confounding factor. But this is the best approach that we can get. Of course, in the future, we have to think to include as many confounder as we can about SSCs, different nutritional facts, whatever. Of course, with this kind of post hoc analysis, and this is an important limitation, we cannot demonstrate because it's not the intention to treat. We cannot demonstrate any effect, of course, for secondary components or individual components of the MACEs because we have a limitation in the statistical power. But I think that we have to think about with the evidence that we have today, which is the kind of design that we have to plan in the future. And of course, the CPAP adherence is a key factor, and to evaluate in the short period times and not a mean follow-up time in 4 years, and to look for the confounder and to improve the CPAP adherence. And also an important point, and for me, this is the last point I want to mention in this first part, about the profile of the patient. We focus in asymptomatic because of ethical reasons, of course, but we have a huge number of different phenotypes of patients that we discussed this in a ERS research seminar that was held in Lisbon several weeks ago, where we discussed that we have different profile of patients. Some of them could be also protected by obstructive sleep apnea because they are survivors. Some of them have a second or a third cardiovascular event. When we compare in a paper published in Blue Journal in the ISAC trial, the group of patients that were included with the first event and no previous cardiovascular history, this was the profile of the patient that were affected by the deleterious consequence of obstructive sleep apnea. So again, we have to think to build new scenarios about the randomized control trial that we have to plan in the future, considering also that the PIT can identify the adequate endotype of patient.
Well, thank you. May I also have some comments here? And I agree regarding the key strengths and the limitations of these trials. And I would also like to emphasize the differences between these three trials because they are different cohorts. And I will also emphasize the importance of timing of sleep studies. As we know, in the ISAC trial is acute coronary syndrome, and the sleep studies were conducted within 3 days. And we see there was an earlier study from SHISA group, and this is just showing that there's a natural decline in sleep apnea activity. And we also had this in the Recurrent trial. We have not published it, but we have as an abstract form. In the untreated sleep apnea patients, we saw that after 1 year, and they were all stable, the sleep studies were done 3 months after revascularization. And we saw that the half of the patients had AHI below 15 after 1 year. They were untreated sleep apnea patients, and 12% of them had the AHI below 5 if we just focus on AHI. So we see that, or we assume that the association between obstructive sleep apnea and coronary artery disease is bidirectional. And in that case, when we recruit new patients, we should consider the timing of sleep studies, and maybe we should include more severe sleep apnea patients in this context. So we also say, as Manu explained, about there is a heterogeneity in the Recurrent trial. We also show that the ones who responded in this RCT group in this randomized controlled trial in the non-sleepy sleep apnea group, they were the ones who had good heart rate response. So there are the ones who responded with a heart rate increase. They got the most significant benefit of CPAP, and we also have other subgroups which may have had some harm if it is too high pressure CPAP levels.
And so I think that this is, if we hadn't conducted these 3 studies, we shouldn't have these results. So anyhow, this is what we have. And all these secondary analyses are important because we also should distinguish the difference between per protocol analysis and on-treatment analysis is also important, because we do not compare the patients, but we compare the treatment periods in on-treatment analysis, which we had conducted in the Recurrent trial. Even if we had a very small sample size, we showed a significant protective effect for the ones who were using the device at least 4 hours per night. But when we conduct per protocol analysis, when we exclude the ones who were using, below more than 0, but less than 4 hours, then it was not significant. So there are such statistical issues as well. But of course, we cannot. This is again the healthy user effect is still there, and this is where we are now, and how we should plan the future projects. So thank you.
Perhaps I can make a comment in relation to that as an author. I think this is a very important and interesting discussion. And while I think the statistical modelling method has raised an interesting issue, I do agree with the comments of Dan Gottlieb that this healthy user effect or adherer effect is quite powerful, has been shown across many studies, and we need to be very cautious in our interpretation. And I think the last paragraph of the paper, we attempted to do that, but perhaps we should have been a little bit more robust in our commentary there. And I think it does, mean that we need to understand this healthy user effect, because I think, as Dan has said, we really don't have a handle on it at all. Socioeconomic factors, even depression, things like that have been measured in many of these studies, at least at baseline, do not eliminate this health and have very little effect on the hazard ratios. So I think we do need to think very carefully about it. And, from a practical clinical perspective, there's also a cautionary note, I think. If we're going to say to our patients on the basis of this study and the findings thus far from the RCTs, that actually if you use the treatment more than 4 hours a night, you will get a benefit. But because those survival curves in the intention to treat analyses are virtually superimposed, the logical conclusion from that is if you're losing it less than 4 hours a night, you're going to have a worse cardiovascular outcome than if you hadn't been given the treatment at all. And so, you have to be very careful, I think, in terms of using this for clinical purposes. So there's just a couple of comments I'd like to make. And Kelly, you might like to make some comments. So I'm not a biostatistician. I was led along. I think there's some powerful aspects to this approach, but it is, after all, a model where you take confounders and you put them into the model. And of course, some of the confounders, and some of them you've measured and some you haven't. And there are many other known confounders, and I would put the healthy adherer effect into that category at the moment. Yeah.
Absolutely. Thank you, Doug. Yes, I agree. I think the team science absolutely is a strength here. And just on that note, I want to comment from a data management and a biostatistical perspective here that the team put a lot of thought into designing this analysis and thinking, how did we collect these things across these different trials? How can we merge the data sets? How can we sensibly combine this information to give us the best possible way of analysing what we have available to us? And even though the outcome definitions were the same for the SAVE and ISAC trials, we found when we were trying to combine the data sets, little things like, how did we measure or record the antihypertensive drugs? And how did we record smoking? All of those things took up an inordinate amount of time in getting the project off the ground. And I'm sure the colleagues in the Spanish group will attest that the team science is a huge achievement here. So I want to thank our Spanish colleagues for leading the way with that. But on that note, we can only include in the model the things that we could include across the 3 data sets. And so that doesn't include everything. There are definitely things that weren't measured consistently across trials, or that weren't measured at all, or that we don't know how to measure. And I think those are really important. The inverse probability treatment weighting is a model that's been developed in the world of causal inference, comes from some of the giants in the field of observational epidemiology studies, is well regarded, but we can only use what we have in the data set.
And Dr. Ryan has a question, and then after that, I do want to ask Dr. Sawyer to step in and just give her comments about adherence as well. So, Dr. Ryan.
Yeah, I will be quick. Thank you so much for this really wonderful discussion, and also very important discussion. I fully agree with Daniel and Doug about the healthy user effect, and it's something which we need to consider. But on the other hand, what the study has also shown us is that we can't dismiss CPAP as a potential helpful strategy in mitigating cardiovascular risk. And congratulations really to all the 3 trials, because they have raised an awful lot of questions as well before we can define the effect of CPAP. So beside obviously the compliance aspect, did we look at the right patients, like is it more effective in primary prevention, and then obviously the aspect of the sleepy subjects versus the non-sleepy subjects. So I think one is the important message here. We cannot also say the study was negative and we can dismiss CPAP therapy.
Thank you. And then Dr. Sawyer, you do a lot of work in this area of sort of CPAP adherence. Just like to have some of your comments.
Yes, thank you. Thank you to the panelists and to the authors. Wonderful discussion. So my work is in CPAP adherence, and we've discussed in preparation for the work for today's discussion, what are the determinants of CPAP adherence? And there's decades of research in this area that span small preliminary studies and larger studies and secondary data analyses from large-scale trials, in fact. So I thought the best way to give the landscape in terms of CPAP adherence was to just put the factors that are most consistent and measurable on a slide and share that with you. So I tend to group the determinants of PAP adherence in terms of patient characteristics, patient context, treatment context, and then more exploratorily, the socio-environmental context, which we really haven't done a lot of work in that area yet. But in terms of thinking about time-varying models, this particular context may be highly relevant, as well as the treatment context. So in terms of patient characteristics, these are measurable factors, right? Basic characteristics such as being a male, older age, white, higher AHI, symptomatic, and typically these are measured at baseline and are readily available, whether by simple questionnaire or extraction from the EHR. And these, in fact, have been shown to be consistent determinants of CPAP adherence, though they contribute relatively little in terms of explaining the variance in CPAP adherence. And then moving on to think about patient context, these are the factors that are innate to the individual patient. And some of those predictors or determinants or factors associated with CPAP adherence include treatment self-efficacy. And I want to emphasize that when we've looked at self-efficacy in the field, we have focused on CPAP-specific self-efficacy. whereas we haven't looked at general self-efficacy. And I think that's an opportunity as we look forward to understanding the healthy adherer effect. Active coping style versus passive tends to is a determinant of CPAP adherence. The presence of a spouse or approximate social source of social support is influential on CPAP adherence. Consistent pre-CPAP bedtime, and most recently we've seen morning chronotype as a predictor of adherence, and sleep onset timing. And then you can see that many of these have been driven by behavioral theory and have actually underpinned a lot of the CPAP adherence interventions, in fact, in the field that have been tested and have shown positive effect. Most of these are measurable with validated instruments, not readily available, so not easily extracted from EHR sources, so would need careful planning in terms of incorporating it in large trials. And there is some differences between studies in terms of how robust these are as predictors or determinants of CPAP adherence, but they do contribute a significantly greater amount of variance in terms of explaining CPAP adherence, anywhere from 20 to 40%. And so what we haven't seen is really a comprehensive evaluation of all these factors in one study. Of course, the measurement aspect of that sounds quite burdensome to both the investigators and the participants likely. And then thinking about treatment context, we clearly understand that early use is associated with longer term use, and that consistent early usage patterns are reliably deterministic of PAP adherence. And then early treatment experiences. But again, these are not baseline factors and require on-treatment evaluation and data abstraction, but readily available, particularly in that telemonitoring is now a recommended standard of care. And so these data are readily available to us. And then finally, I want to speak to socio-environmental context. We're just starting to see some work in this area, thinking about social determinants of health, the balancing of prioritizing one treatment or the use of one treatment over other demands and pressures on a daily basis within a patient's life, familial care demands, the cost-benefit perspective from the patient or the user side. And then thinking about relationship with healthcare, the system more broadly, and with the individual provider who's recommending treatment. These socio-environmental context variables, some of them are measurable, some of them are more complex to think about measuring even. They're not readily available, and we don't know if they're influential on CPAP adherence specifically. There have been some preliminary studies recently published, one by Dr. Wallace, looking at the experience of racism and its influence on PAP adherence. And then there's a relatively large study underway, the SEMSA trial, looking at health literacy, self-efficacy, and several other variables that are more socio-environmental in context that may be influential on PAP adherence, and looking at it over a longer term than what we've previously looked at. So this gives you a sense of what we know about factors that influence CPAP adherence, both adherence and non-adherence. And as we think about that, which of these factors are also associated with other health behaviors? For example, chronotype has been associated both with PAP adherence and healthy lifestyle behaviors in cardiovascular disease. So there may be some of these that we would want to prioritize, because certainly the comprehensive nature of measuring all of this within any one study sounds quite daunting.
Excellent, thank you very much. And this also leads the discussion further what we should consider when we design future trials. And certainly we need to consider these aspects and also how to measure these. Do you have other ideas what is very important when we think of randomized controlled trials in this field, of course, and cardiovascular prevention? And what is especially important to consider also, for example, as a comparator to control for certain things compared to observational trials, or what is different or most important to consider when designing such studies in the future? The question goes to all, whoever would like to answer.
Well, I think that Yüksel pointed to one set of things that are going to be important to design of future trials, and that is that we're now there's a fair amount of work going on looking at both data from both observational studies and these clinical trials to identify physiologic measures that predict both cardiovascular risk in non-sleepy individuals, but also that appear to predict a benefit of therapy, such as the measures of hypoxemia or measures of autonomic response to respiratory events. And I think that those things need further validation, but I think they'll be important in the design of future randomized trials to be sure that the patients included in those trials are a group that really is at sleep apnea-related cardiovascular risk.
I have also some comment about this important point, because as I mentioned before, this kind of a study have to allow us to think about the future, about how to build this new scenario, this new randomized control trial. For me, the most important are 3 points. The first is the profile of the phenotype of the patient, okay? When we design Recurrent, ISAC, and SAFE, this happened 13 years ago, 14, 15 years ago. And in this moment, we consider that all asymptomatic patients, of course, had to be included. Also, we consider the composite outcome. Maybe it's not the best approach, because we have important information about the effect in the cerebrovascular is different in the cardiac outcomes. Maybe we have to identify and to look for specific more well-defined outcomes and not to avoid composite outcomes. And also, of course, the message that we have from this individual patient data is the meta-analysis, and for this meta-analysis, the Adherence, like a key factor in secondary cardiovascular prevention. Because also we have to think about some important, very recent trial, very recent study. I'm thinking about one of them published in Blue Journal, I think this year or 2023, about the moderate intermittent hypoxia have therapeutic effects in patients with obstructive sleep apnea that were treated with CPAP. In the morning, they receive moderate exposure to intermittent hypoxia and decrease the blood pressure. So we got to think about to define well who is the profile, who is the patient that is really exposed to the deleterious effect of obstructive sleep apnea.
I guess maybe I'll pose a question to the group as well. And I think when we do these trials going forward, if we expect that the adherence to see, no matter, even if we find the optimal patient group that's going to most benefit, if the adherence to the treatment is only 30-40%, it is difficult, right? Even if we're doing a placebo-controlled pill, a lot easier, but we only knew it was going to be 30% effective, our sample size would then have to become enormous in order to show effects. And so it's just a question for the whole group, I guess, is, you know, are there other approaches we should be taking in future trials to optimize adherence, or other approaches in order to get a stronger signal, if they're really, because I think even if there is a signal, if all we see is 30 to 40% adherence, and again, there are some questions about what is optimal adherence, but curious what the group thinks about future trials.
Perhaps I can make a comment there. In the SAVE study, we had a brief run-in with a dummy CPAP machine that didn't generate a therapeutic pressure. And we had a pretty, you know, modest threshold for getting into the study. And you had to show that you could use it several nights a week for 2 nights, for 2 weeks rather. And I guess one way of doing it would be to just increase the threshold and say, we'll only take people into the trial who are super adherers to a placebo or a dummy CPAP machine. And if you then choose a highly susceptible, or you think based on the physiology, a very high risk group, you perhaps wouldn't need as many participants in your study. And of course, I think from this paper and this analysis been done, it raises the hypothesis that if you are a very good adherer, you may get a benefit. So you need to find the very good adherers and put them into your RCT. And then I think you'd be at least answer that question. That is, if you are in the good adherer group, can we find a benefit from using this particular device?
I think maybe there's 2 questions there about effectiveness and efficacy. In terms of, you might get an answer to the question about whether CPAP is useful for those particular patients, but that doesn't help in deciding whether to prescribe it to any particular patient who comes into a clinic, because you don't know in advance how well they're going to adhere. So I think there's 2 questions underlying that. One is the theoretical one about whether CPAP works, and the second is it going to work for this patient who's come into the clinic today? And then they may be not the same question necessarily.
That's Sawyer.
So just to follow up on Dr. McAvoy's discussion about a run-in, I can see the utility of having a run-in at the outset of a carefully designed trial. But we also know that PAP use attenuates over time. And so the excellent performer in terms of adherence during a run-in period may not sustain PAP use over time at an amount great enough, a dose, that my term, to demonstrate the effect that we're looking for, that we believe we should see at the end of these trials that are looking at longer term outcomes. And so it makes me also wonder if, you know, in most trials and in practice, we tend to front end load our adherence interventions, right? And, you know, be available to patients or participants over time for troubleshooting, but not deliver sustained interventions aside of the protocol for PAP adherence. And so I'd be curious what the group thinks about, you know, do we need to actually consider adherence intervention approaches embedded within the protocol over these long-term trials where we're looking at longer-term endpoints?
Very short, for me, 2 points, very important, very important. The first is the quality of the device. We have a huge different device providing CPAP therapy. Not all of them have the same quality. So the sensation of the adherence of the patient could be also related with the quality of the device. And the second is that we have a very well-established telemedicine approach to have information in real time about the adherence of the patient. These are 2 points that we have to use, of course, in the future.
Well, I have 2 additional comments here. I agree. I think that this is the running period is important. And in the Recurrent trial, we we just controlled the adherence at 1 month, predicted the adherence at 2 years. So I think maybe we can extend this from 2 weeks to 4 weeks of running period. Could be a good approach. And we should also think about the primary and secondary prevention, as Manu explained before. I think we are talking about different targets, and we know that there are good evidence for protective effect of CPAP or good effect of CPAP in hypertension, in hypertension. And also for cardiovascular disease, for coronary artery disease, it is a bit maybe too late, and they have all other comorbidities, and they have, I think, half of the ISAC population were current smokers at baseline, and it's also, again, they have hyperlipidemia, and they have all other confounding factors. So it's really very difficult to change the outcome with only CPAP used 3 hours every night. So we should be, of course, we should think most about that. And I will also just comment about, I don't know, it's also a kind of question, just using fixed pressure or automatic positive airway pressure, because just given that the association is bidirectional, and some nights they may need higher pressure, some nights they may need lower pressure, and we should be very careful about increasing the maximum pressure regarding the latest findings we had with angiopoietin 2 levels, which seem to be very interesting. I think we again, the choose of CPAP device. PAP device. We have a recent paper with adaptive servo ventilator with Michael Arts and his group. I think we should be very careful about which clinic cohort we are talking about, because the outcomes may differ, and as the adherence is very important, again, all these behavioral aspects is coming on with COMISA and insomnia and other anxiety, and it seems that we really need to include CBT in the randomized control trials as an additional arm in these in future trials.
Those are excellent comments, and I think they relate to some questions that Dr. Shiza entered into the chat around what is the duration of CPAP that's necessary to achieve cardiovascular outcomes, and is the duration of CPAP use that is necessary to achieve a given outcome, does that differ based on that outcome? If there's any other quick comments on that, I think we have maybe time for one other question or comment before we wrap up.
I'll just maybe add that I think there's an interesting evolving story about the night-to-night variability in symptoms or severity or hypoxia or sleep disturbance, and I think that is going to become important in how we measure the severity of people's disease, but also the effects that it has on their health risk as well. I think that others in the team here at AISH are working a lot on that, and I think the story there is going to be interesting, and we're going to need to take that into account in how we think about criteria or thresholds for recruitment in future trials.
Well, excellent. I think given the time, it's I hate to end this discussion, but I think we should probably wrap up and say some closing remarks. This has been an excellent discussion about what is really a critical and important topic for our field and for really society at large. Given the scope of sleep apnea. And untangling these issues is going to require ongoing work and dedication of the field and more collaboration and more research. And so on behalf of Dr. Schwartz and Dr. Kunisaki, I really want to thank first I want to thank the authors for their participation today and their commitment to team science and all of its challenges and complexities and nuances. and all that work that formed this excellent paper. I also want to thank our panelists for all their time and wisdom today, and for their collective work that's formed the discussion that we're able to have today. And major thanks as well to the ERS and ATS for collaboration in making this possible, and for everyone's patience as we've rescheduled this event. And certainly, perhaps most importantly, we were certainly remiss if we didn't thank the audience for joining us today, and for continuing this conversation going forward. Just can't thank everyone enough for their time, and thank you.